So good afternoon, delegates, ladies and gentlemen, both in the room and online. It's lovely to be here, and thank you to the organisers for inviting me to contribute. I've learned a lot from you speakers this morning, and certainly it will inform my practice going forward. Today I'm just going to give you a clinician's perspective and talk to you about the importance of clinical trials in pregnancy. Thanks. So I have been working in this area for about 30 years as a clinician and researcher. When I started in this area, I was told very clearly, no clinical trials in pregnant women. They're a vulnerable population. Pregnant women don't want to contribute. You might be endangering the infant. Lots of reasons, and as a result I stepped well back and I thought no clinical trials in this population. So I stuck to just observational data, which actually over time has helped me enormously in engaging further in clinical trials and actually making progress. So diabetes in pregnancy, for those who don't know, is one of the most common clinical conditions that are encountered in pregnancy, and 1 in 6 pregnancies globally is affected. And the majority of cases of diabetes in pregnancy, when you look at numbers, are in emerging countries. The treatment of choice is insulin, but insulin is not available in many emerging countries. And if it's available, you don't have a fridge for it or you can't afford it. So it's really important that we continue to research in this area so that we can find alternative solutions for women. So this is just to remind you again what equity, diversity and inclusion are about. Everybody in this room now is familiar with those terms. But together, these principles offer a systematic approach to improving clinical trial design and conduct. So it's really that they should be always foremost in our mind and not as add-ons. We get more information from the European Medicine Agency through their EU clinical trial regulation. And they tell us that unless justified in the protocol, subjects participating in the trial should represent the population groups that are going to use the medication that's in that trial. So really, for me, that means you can't pick and choose who you want to go in. You have to really go through it systematically to make sure everybody is included. So clinical trials are really important in pregnant women with diabetes. So if you have a sugar problem in pregnancy, not only does it affect you, but it affects your infant, and there is transgenerational changes in all sorts of things that give the infant worse clinical outcomes for the future in their life in terms of cardiovascular disease, obesity and diabetes. So it's really an area that we need to keep foremost in our head. And research in diabetes in pregnancy is needed really to advance and inform healthcare decisions and treatment options. If we can ensure that we have healthy mothers, we'll have healthy infants, and then this drives better population health going forward. Participation in trials allows women to gain access to important new technologies and medicines long before general populations as part of the trial. We know for all clinical trials, but more importantly for pregnancy-related clinical trials, that healthcare is better in institutions that deliver trials. And then trial results, if we're to bring the trial from inception to delivery and its impact, they will inform policy and guidelines both in your own country and internationally. So it's really very important. However, as you can see, in 2017, only 0.32% of registered trials were pregnancy drug trials. So really it's an evolving and new area. Now, I've engaged in clinical trials in Ireland as a site PI for many of these trials here. And these trials have all influenced clinical practice, both in our country and internationally. These trials are driven by questions that appear in the clinical space. So how can we improve outcomes for women in pregnancy, either through new technologies or through new insulins? So you can see the EVOLVE trial and the EXPECT trial were sponsored by Novo Nordisk, and they were looking at new insulins. And of course, because it was a new insulin and it was an analog insulin, people weren't inclined to use them. But these went through rigorous clinical trials and now are part of clinical practice. The CONCEPT trial looked at continuous glucose monitoring instead of finger prick testing for women throughout pregnancy. And continuous glucose monitoring is now routine practice for women with type 1 diabetes. And more recently, the ADACT trial looked at closed-loop insulin delivery in an automated fashion for women with type 1 diabetes. And now this is gaining momentum and will become routine care for women with type 1 diabetes in pregnancy. So in 2017, we looked at, we designed first and started to implement a trial called the EMERGE trial, which was funded by the Health Research Board. And this trial was looking at an oral medicine called metformin, which has been around for 60 or 70 years. And we wanted to look at this medicine in gestational diabetes, where the usual form of treatment was insulin delivery by injection 1 to 4 times a day for at least 12 weeks of pregnancy. So we were looking to see if this medicine would inform our clinical practice, be as equal or as good as insulin, and give people a choice. So we kept the research question very simple. So among women with gestational diabetes, does early metformin added to usual care reduce the need for insulin, reduce maternal weight gain, reduce maternal and neonatal morbidities, and reduce the cost of treatment? So very tangible things that everybody could buy into. This was a really important trial for us because it was the first double-blind, placebo-controlled trial of a large number using this medication in women with gestational diabetes. So we were very keen to get it right from the beginning. So metformin or placebo were given to women in a randomized fashion, and the metformin dose was up to 2,500 milligrams daily, titrated over 10 days, and the placebo was matched in every conceivable way to the metformin. We used a primary composite outcome that was of value to women and also of value to clinicians and the healthcare delivery process. So unlike other trials that were looking at pregnancy outcome data as the primary outcome, we were looking at insulin initiation or a fasting glucose greater than 5.1 at week 32 and 38. And this was a combined outcome because it measured metformin failure in 2 discrete ways. Insulin initiation is important for the women. They don't like stabbing themselves. Insulin initiation is also important for the healthcare delivery system because if you start insulin, there's an education program and a nurse follow-up and everything related to that. So we kept the eligibility criteria as broad as possible. So you could come into this trial if you had a diagnosis of GDM, if you were carrying 1 infant, and if you had no contraindication to the use of metformin. So we kept it very simple. We included all BMI categories and all ethnicities. So although EDI wasn't top of the list back in 2017, as you might imagine, intuitively for us as clinicians, we knew that we had to focus on the type of people that were coming into the trial. And that's because women with GDM, the prevalence of that increases with age, the prevalence increases with increasing BMI, the prevalence is greater in women of other ethnicities rather than Caucasian, and the prevalence is greater in lower socioeconomic groups. So in our heads, we knew that although we were in a white Irish community, we had to search out for these people and make sure they were included. So from the very beginning, our advisory group, which had the usual people, obstetrics, midwifery, dietetics, diabetes, and so forth, we also had 2 important contributors. We had a lady from an association called AIMS Ireland, and that's an association for improvements in maternity services in Ireland. And we also included 2 women with GDM, one with previous GDM and one with current GDM. And they were really very instrumental in our discussions at these advisory meetings about progress. We also had a very active PPI group. They had helped us in the design of the trial for the grant application to HRB. They were very active with us. And once we had our funding and were ready to go, they engaged with us again, and we had numerous discussions on the PIL and the consent forms and, you know, when patients could come and how we could make it easier and so forth. So again, very helpful. What we needed to do, however, was to know first what our regional population was like. So we knew we were in a mostly white Irish population, but we had to get census data and local hospital data and county data to try and analyse, to the best of our knowledge, what was the population we had at the moment. So about 76% were white Irish, 2.5% were African or black, 14.1% were of Asian ethnicities. Other ethnicities were put together as a small group because there was only small amounts of all of those. And then we've one special ethnic group in Ireland, the Irish Traveller movement. Now, the Irish Travellers are like a nomadic or Roma type of population. They have special ethnicity status within Ireland. They're a group of people you would want to include in a trial like this because they have at least double the rates of diabetes, obesity, gestational diabetes. They die on average 15 years earlier than people who are not of that background, mainly from cardiovascular diseases. Now, these people are rarely included in anything because they're considered to be too much bother. And the reason they're too much bother is that they often don't comply, they don't come to clinics, they don't do what you tell them. But that was no reason to exclude them, so we actively went after this group of women. So 77% really of our population were Caucasian, about 23% were ethnic varieties. We lived in a university city and a university county, so we expected that the population would be very much dominated by people who had achieved third-level education, but we also wanted to include the other populations of primary and secondary. It was important for us to understand fully the healthcare delivery system because that told us where we had to go and find women. So in Ireland, if you have diabetes and pregnancy, you can come to a fully funded public health system clinic where you can get care from midwifery, obstetrics, diabetes, dietetics. And lots of women do that. However, there is a choice. So women can choose to go and see an obstetrician privately in their consulting rooms. They can pay for that up front, or else they have private health insurance. And that's a population that we had to target also because we didn't know, how much prevalence of diabetes was in that group, and we certainly wanted to get them in. So really, when we analysed all of this, we concluded that about 53% of the population were attending public clinics, about 47% were in these private clinics. Now, we have another thing in Ireland called the medical card, and the medical card is available to people of very low income. So the use of a medical card is often a proxy estimate of low socioeconomic group. So about 25% of the population have a medical card, and that entitles them to free hospital care, free GP care, and free pharmacy care. So all of this information was really important in the design of the trial and how we approach things. So really, before we did any recruitment, we looked at our exclusion criteria again and made sure that they were very limited. We did several iterations of the PIL and the consent form, making sure it was easy to read. We designed posters and leaflets, mainly with the help of the PPI group, for the antenatal clinic areas. We also put those posters in all hospital wards because a lot of Asian women are now engaged as nurses and nurse assistants on our wards. We put posters and leaflets in GP practices and pharmacies because that's where a lot of people go when they're pregnant for additional help or if they're requiring over-the-counter medications. We went out and actually visited the community. So we went to GP practices and educated them. We went to the private obstetric practices and educated them. We talked to the translation service, what they could provide. And then importantly, we spoke with the link workers and engaged with them to get to the population of migrant women and traveller women because we were keen on making sure we included all of those. We then provided an extra clinic per week where we could see women with a new diagnosis of gestational diabetes outside of the busy hospital environment, where they could bring their partner or a family member, and there was plenty of time for discussion about the trial. So in the early time of this trial, in the first year, we did 2 pieces of qualitative research to help us understand that we were doing things properly and to ensure that we were doing the consent well for this vulnerable population of women. So the first was a piece of work to explore the decision-making process for women in the eMERGE trial and really to explore the factors that would influence that decision. And the results of this piece of work really informed how we continued thereafter. So this was a qualitative piece of work. The results really came out in 3 main themes. So 3 main themes that made women consider and participate in the trial. One was the perceived benefits of participation. The second was the recruitment process itself. And the third was the trial design considerations. So firstly, if you look at the benefits that the women considered when making their decision, one was the impact of a GDM diagnosis and finding a more favourable treatment. Second, avoiding or delaying insulin was important. Benefits of the involvement of the trial in terms of extra monitoring and support, they felt that that was important. The potential benefit to their baby and reducing adverse effects, and altruism came across as an important factor for these women. So although they may not get benefit in the trial itself, they were keen to participate for future generations. Now, the recruitment process was considered very carefully by these women when they were making their decision. They liked the fact that the PIs and the sub-PIs were part of the clinical care delivery process, and that allowed them to trust the clinical team and the research team strongly. They liked that there was availability of the research team at all times and that the research team was knowledgeable. They liked the personal interactions, but liked to receive both verbal and written communication. They sought out testimonials from other patients which influenced their decision, and they wanted plenty of time for consultation when making a decision to consent to the trial, all of which were taken into consideration going forward. Now, this area I didn't consider would be of importance to women, but it actually was of significant importance. So the ladies acknowledged the importance of placebo control in the trial and its impact on answering the question, and they were in agreement with this. They didn't think that this was a problem. They liked the nature of blinding by the trial staff and by the clinical staff, because then they felt everybody was treated equally. They liked that there was an unblinding process available in case there was difficulty. They understood and were accepting of randomization, which was not a barrier, and convenience of the study visits was important. So all of this helped us in the process of recruiting into the trial going forward, allowing plenty of time, making sure that the trial visits were on the same day as their clinical visits. So overall, we would say that women were very positive in participation. Altruism was very important. They viewed aspects of the trial design and they were very positive about these, and we spent a lot of time on these in the consent process after that. Orderly trial administration, they don't like fluffing, coming and going and nothing being organised. So everything had to be organised for these women and we had to maintain trust. Now, the second thing we looked at was the consent process. Because we were dealing with a vulnerable population, we wanted to ensure that we were doing the consent process correctly. So we wanted to assess the quality of the consent process. Again, this was observational. So we used this questionnaire of informed consent to assess how good or badly we were doing with the trial. So what we found was that 100% of participants gave correct answers on those following questions. Greater than 95% gave positive answers on those questions. But you can see on the bottom, 70% gave incorrect answers about the experimental nature of the trial and the study treatment that was not proven. We did subjective assessments and they scored pretty well on those. The subjective assessments in red were always higher than the objective assessments. But the conclusion was that we were doing it pretty well. There was good understanding of all aspects of the trial. And interestingly, a trial consent was anywhere from 15 to 90 minutes, but on average 32 minutes. So how did we do when we recruited into the trial? Over the 5-year period, including COVID, we approached 2,308 women. We got 535 women into the trial, equal numbers in metformin and placebo. And importantly, we had 98% of the trial participants for the primary outcome data. So very few people left the trial. The trial characteristics you can see here, 80% of the population was Caucasian, and that's what we found in the trial. 20% were of other ethnicities, so that's over 100 women, that's important. Down at the bottom, you can see that we had about a quarter of women on medical cards. Again, that's over 100 women of lower socioeconomic group. About 45% were private health insured people and about 8% were unemployed. So when we can compare the recruitment into Emerge versus the background population, you can see that we covered all aspects that we had set out to achieve. So this trial was published in JAMA at the end of 2023. Unfortunately, the primary outcome, which was a composite primary outcome, was not any different. However, the components of the primary outcome in terms of insulin and fasting sugar were significantly better in the metformin women. Women on metformin gained less weight and had better satisfaction in the trial than those on placebo. And the outcome for the baby was very positive. We were able to reduce the excessive growth of babies without any increase in neonatal morbidities, which is an important consideration. So although the trial was not statistically positive, it had very important pre-specified secondary outcomes in favour of metformin. And more importantly, at the bottom, there were no increase in neonatal or maternal morbidities and no increase in preterm birth, which was seen in previous studies. So to conclude, clinical trials in pregnant women are essential to advance treatments and improve outcomes. Women with gestational diabetes are positive about clinical trials and want to participate. They're very knowledgeable and understand aspects of trial design when you take time to explain it to them. And it is possible to fulfill EDI in trials of pregnant women with GDM with careful planning and review of the recruitment process. Thank you.